whole list of questions for you, as I guess everybody else seems to all the time.
Well, thank you very much for having me.
You wrote an opinion piece, and I can't tell you how many people sent it to me, first of all. And that's just in my small group of people. But this is a conversation that is you've been having for a long time, but a lot of people are just starting to hear and just starting to really talk about. So, first of all, can you talk a little bit about, we're going to go into your history, but talk a little bit about what brought you to write that piece and write it now?
Well, I've been doing this for 30 years, and so I have the vantage point of having practiced in an era before the Women's Health Initiative came out, during, and then the 20 years afterwards. And I mean, what's astounding to me is that it's been 20 years since this study came out, and we are still dealing with the repercussions. I mean, and I think bad news is very sticky. And it persists, and it has been for in these 20 years since this study has published. And this is a large study done at the National Institutes of Health, which actually was looking at hormone use in the prevention of cardiovascular disease for women. And the study was stopped early. It was supposed to go for 10 years. It was stopped after 5 years in one arm and 7 in another, for reasons, saying that one, there wasn't any benefit to cardiovascular disease, and there was an increased risk in breast cancer. And that was all everybody needed to hear. The study was stopped. Women went off hormones in droves and suffered tremendously as a result. So it was that piece of it. I think a lot of patients felt betrayed, because we were advocates for hormones before the results of this study came out. And and since that time, gradually, each of those results has been walked back, but nobody got that message. And so women are still dealing with information that's 20 years old, that's been revised. We've understood now what the limitations were of that particular study, and we're still stuck in in 2002 as far as what our understanding of hormones.
I mean, we're talking about 2 decades later, and everything came to a screeching halt, which is just so sad when you think about what could have been accomplished and the number of women that could have been helped during that time period. And no one's seeing that more than you are. What's astounding to me is the fact that I don't think any of us even knew where the fear came from, right? So I didn't know until I started diving into the research of really I didn't know what a 2002 study was. I'm a woman that hit menopause, didn't really know what it was. I didn't know what that was. I just knew that hormones were bad. In my head, that's what I thought. And because I'm the daughter of someone who had breast cancer, and at a very young age, diagnosed at 44, I was deathly afraid of hormones. Then I hit my own story, and then I got the truth. But it's like each one of us have to peel apart the truth one at a time, and that is not helpful, not only for the medical community, but also for women as a whole. How do we change that message? I mean, obviously pieces like yours, start to do that, but this is very ingrained in our minds, and most women don't know where it came from.
Right. And not only, it's so embedded in the thought processes of women. But not only women, but doctors, because in those 20 years that have gone on since the Women's Health Initiative was reported, there's a whole generation of doctors who think that hormones are bad. And if you don't pay attention to it, and this is something that I think is really unfortunate, because having been there when the study was released, immediately when you read it, you realize that it was not nearly what the headlines even reported then. And I use the analogy, but I said it's the Mueller report of medical, investigations, because there was a lot in the study and a lot to be parsed. And all the only thing that came out were just those two things, and it stuck. And doctors, as well as patients, were abandoning hormones in droves. So taking the time to have to explain this to women, it takes a lot of time, because it's not a yes, no. And I think a lot of people just decided, we didn't have time for this conversation, or it takes too much, effort to try to parse it. And we just left it. And the true unfortunate thing that happened is that women's research in hormones has stood still for these 20 years. And there's been nothing that's been comparable since then. And I think that at this point in time, we're due a do-over on that study, because all of the data that's come out since then is very positive. It's walked back a lot of that, and women deserve the answers about what to do in their postmenopausal life. And we're going to spend a third of our lives there, so it's important.
Yes. We sure are, and we're going to feel every bit of it. I'm afraid, we also talk about the fact that it's created such a toll, and you reference this, but a public toll as well. The study that you talk about was a 2021 study of women that are in different parts of menopause and affected on the job, and I was one that was affected on the job, and I didn't know what was going on. I thought heart attack, I thought Alzheimer's. I went down the whole list of anything that I thought it could possibly be, right? But there are some women that are not able to function at all, or don't have the luxury that I had, where I went and told my bosses what was going on, and I was able to deal with my symptoms. But some people don't have that.
I think it is. I think it really is going to create some pressure, because this has to be a grassroots advocacy. Women have to demand it, because let's just say the notion that someone's going to come and save us, and fix my problems, not going to happen. So I think that women, the more education that women get about the signs and symptoms of menopause and what to do about it, and how to approach not only their healthcare providers, but their employers about what they're going through, we're going to demand a change. I mean, just think of what's happened in the past generation, breastfeeding mothers, in terms of, they said, look, we are not being accommodated in the workplace, so we need to fix that. I think that menopausal women have to say to their healthcare professionals, we need answers, and it's not okay to just brush it under the rug or just say, don't worry, dear, just suffer through it. I'm not a fan of suffering. I don't understand why that has become the normal default for women after a certain age. And I think that we deserve to feel better. We deserve to weigh our options, because I trust that if you give women information, they can make decisions for themselves. And there is not a tension that I think it's sort of a false controversy that goes on between pro and con, hormone users. At the end of the day, I've always said my job is not to advocate for hormones. My job is to advocate for women. And I want you to know what you have access to. If you don't need them and you are doing great, then fantastic, not talking to you. But for the people who are symptomatic, I refuse to let women be shamed into not wanting to take an option that's not only safe, but that's effective. And that's sort of my message.
Well, and I wonder, and I love to hear it, honestly, because I was one of the ones that was afraid, and I didn't even know why I was afraid. And not only was I afraid, but just given my mother's history, that was what was told to me. And I remember walking into an endocrinologist's office, and she pulled out a calculator, and it had little gems on it. And she was calculating, this is a year and a half ago, calculating my risk. And I sat there and I went, first, I haven't seen one of those calculators in years. And second, is that how we assess whether or not it's safe for me to have hormones? And it was really shocking to me. Is that a normal thing?
Oh, well, it's not part of what I do, but I know exactly what you're talking about, that little model.
Oh, good.
For what your risk of developing breast cancer is. And I tell you, and here's something, and I mean, here's the good news and bad news about the campaign for breast cancer, is that I think that, again, this is, advocacy at its best, getting women educated about screening, understanding, what to do, when to consult. That is fantastic. Okay.
Sure.
And that's why breast cancer and the death rates from breast cancer are going down. But the risk for breast cancer can't overshadow everything else about women. What about your risk for osteoporosis? What about your risk for type 2 diabetes? What about your risk for cardiovascular disease? These are all things that have to be taken into account and really weighed in that decision of hormones and no hormones. And I think that we should declare some victory there on the breast cancer front, because, a woman who's diagnosed today in 2022, 90% of those women will survive. That was not true 30 years ago, 40 years ago.
Mhm.
So there's a lot of good that's come from that movement, but it shouldn't block out the sun. That's all, that's all I want to say about that. And I think that the more women understand about the fact that, we all talk about hereditary breast cancers, 95% of breast cancers are not hereditary. And whether or not you get breast cancer in your life depends on a lot of things. They're environmental things, your diet, your weight, the age at which you've had a first child. They're things that may or may not be changeable, and you need to know what those are as well. But just having a family history of breast cancer, and I've had two sisters who've had breast cancer, vastly different breast cancers, one at 37, another one at 70. They're not even the same, type or the same disease. So a blanket family history of breast cancer being a disqualifier is also something that requires a little bit more discussion.
I'm so empowered to, the documentary in part is because I'm just so empowered to try to create some type of change, because I know that when I started my the breast cancer screening, they wanted to go 10 years before, right? So when I was 34 years old is when I started my first screening. And I just am confused why we don't piggyback menopause, at least awareness, in that same time period to say, hey, this might be the time you could also deal with something you've never heard of called perimenopause. And maybe would you do blood markers? Or is that something that's being discussed in terms of, I don't know, where does that go?
You know what? You don't even need blood tests, because the reality is that every woman, 100% of people with ovaries will go through menopause.
Right.
Not option. We know that for the vast majority of women, somewhere between the ages of 40 and 50, you'll be in perimenopause. You just are. So, because that's just defined as that
age.
transition between, being in your reproductive years to entering your post-reproductive years. So it's a clinical diagnosis. It's not really, it doesn't require any scans or blood tests or anything complicated. If you are a woman between the ages of 40 and 50, and there are about 2% of women who will have symptoms before age 40, but for the overwhelming majority of women, if you are having symptoms and you are in that age group, then you are in the menopausal transition and you're perimenopause. Nothing more complicated than that.
And now you need to know what to ask, though,
yes,
right? When you go to your doctor.
And you need to know when you see these symptoms, oh, this is where I am, rather than, and I think what's happened, unfortunately, is that women in that age group who aren't thinking about it or don't even know that it's a thing, they will consult a psychiatrist because they're depressed. They'll see an endocrinologist because they're gaining weight. They'll see a dermatologist because they have acne. But no one is really stitching all of that together to say, it's all part of the same thing. And that's where I think the confusion has come in. And the more we get women educated about the signs and symptoms of menopause, the better they will be able to make decisions about the choices as they occur and as they start to affect the quality of their life. And I think that's important.
Now I know there is, and by the way, I did see two of those doctors. I went to a therapist and then I went to an endocrinologist. I followed right in line with everybody else. There really is also the need, though, for the doctors to be able to discuss this and the doctors to be able to get to the next stage. When I finally found out I was in menopause, my doctor, they were male gynecologists that I had seen through my 20s and my 30s. And when I did do blood tests, and they said, like, oh, your levels show that you are menopausal. In menopause, any questions? And it was put in my patient portal. And that was where it was. It was in my patient portal. And I thought, I remember getting on an airplane, I opened it up and I was like, oh, I'm in menopause? Like imagine all the things that you're processing, right? Like that was the message. It was like the bad sticky note in Sex and the City, we broke up. I broke up with my, my reproductive self. And, but I just find that's just a sin to, that's how you find out. And the fact that there are a lot of doctors that are not comfortable talking about it.
And that's unfortunate because, as I said, after this study, we unfortunately, a lot of women missed the opportunity to be able to take hormones. And then a whole generation of doctors have come of age in the thinking that hormones is bad as well. So, but what we have got to do, and I think this is important, is to have women And I'll back up a minute and I'll say, I'm going to say this in fairness to my medical colleagues, because I know what the pressures are of
Sure.
having to work, see patients. And when you're seeing them once a year, it's hard to get to everything you want to talk about in 15 minutes.
Sure.
So if you don't think to bring it up, they don't necessarily want to bring it up because it is a conversation.
Sure.
It is not a yes, no, take 30 seconds on this and we're on to the next thing. And so I think that the pressures of medicine today and the number of things that doctors have to accomplish in a relatively short period of time hampers that conversation, which is really why when I left my practice, and I had been there for almost 30 years, and I've been having these conversations one-on-one with women. And as a matter of fact, I start talking about perimenopause and menopause for women who are in their early 40s, because I want them to know what's coming up. If you're
Right.
coming in after symptoms, then sometimes that's too late. And I think a proactive approach, but there are not enough doctors who have the time or the bandwidth to do that. I mean, that's just the reality of modern
Right, of
medicine
course.
today. So that's why, when Anne Fullenweider and Monica Molinar, the founders of Alloy Health, approached me about doing this, I said, this makes perfect sense. This isn't a right turn or a left turn from where I was. This is right what I've been doing. And I get to leverage. I have 30 years of experience doing exactly this. And wouldn't it be great if we could take the expertise of a few doctors and give that to women, all across the country? Because the reality is not everyone, whether you live in a big city or a small city, has access to a doctor who knows how to treat menopause.
No.
There are many women who don't even have access to an OBGYN. And when you add to that, only about 20% of OBGYNs feel comfortable talking about it. You can see how great the need is for educating women. So that's sort of our mission. We want to educate women. We want to make sure that they have access to doctors who are trained in menopause, who can help them make that decision. Prescriptions are mailed, hormones, which are, estrogen and progesterone, are mailed directly to patients. Because it's predicated on the fact, too, that we trust women.
Right.
I trust that if I give you information and it is based on scientifically vetted information, and I give you FDA-approved solutions that are not just my opinion, it is the opinion of the American College of Obstetricians and Gynecologists and the North American Menopause Society, if this is what the consensus is, then I can present that information to you and you get to decide. Not your friends, not your doctor, not your internist who says this stuff is going to kill you. I keep up in this space, and the people who are menopause practitioners, we make sure that we stay current with the recommendations. And I don't think that there's any other field in medicine where we constantly get overridden by our medical colleagues.
Right.
And that says something in and of itself, that when it comes to issues of women's health, that I would no more change someone's insulin dose than they should talk to me and change my patient's estrogen dose or steer them away from him. But that happens routinely.
Absolutely. It's always so shocking to me because it feels like they're tinkering in a space that they have maybe 1% in, but having a huge opinion about, because I've heard those opinions from doctors that are not, and I'm now seeing a midlife practitioner, and the conversation that I have with her is significantly different, and part of the reason that I'm working on this, because I really just believe that I'm not a doctor, but I can maybe be a menopause mentor, or I can be somebody that can get the word out. I know how to dispense information. That's what I know how to do. You have been at the forefront also of a new generation approaching menopause, including obviously First Lady Michelle Obama, Tracee Ellis Ross, a number of celebrities that have come forward. What do you think that their voices do to this cause? Because I feel like it carries a great weight and a lot of responsibility, and it's exciting to see.
Well, I think it's important because it changes the face of menopause. I think that everyone has an image in their mind of what they think a menopausal woman is, and it's generally not positive. And the more
Mhm.
people that we can get out there that say, my goodness, you can be beautiful and healthy and fit and vibrant in these years, because menopause has some things, and those are physical things. We can
Mhm.
deal with the symptoms, but
Yeah.
how you function and move about in the world matters.
Yes.
Representation matters. And we have got to not be ashamed of this space that we occupy. Yeah, I'm a menopausal woman, and I am still going to continue to do all the things that I did 10 years ago. And, the more people see that, I think they will fear it less. There will be less
Yes.
shame about menopause. I think we'll be able to have more open conversations about menopause. And that is what I hope that, all of this leads to, is that it ends up being more choices for women. I think we need less people telling us what we can and cannot have, and more people helping us decide what's the best solution given your particular circumstances and what your particular goals are for how we age. And
I mean,
that's
really, yeah, if you know the options at least are available to you. Right now, there's just so much noise and confusion. You can't even get to the options because you've got to cut through all of the noise first, I feel,
yeah.
and fear. What percentage of women that are menopausal are on hormones right now, depending on whether, the different types of hormones I know, but do you know, is there a percentage? I'm not sure if I've read
As
that.
best we can tell, and I think the last figures that I had, I can, because this is an advantage of being old. You've been around for all of it, and
Well, I'm
pre
grateful that you have.
pre pre Women's Health Initiative, which was 2002,
Right.
roughly 40% of menopausal women, were on hormone
Mm-hmm.
replacement therapy.
Mm-hmm.
In Waltz is the Women's Health Initiative. Women are frightened. It's down somewhere around 5%, five to
Oh
six
my
percent of
gosh.
women take hormones. Only, and you'd be surprised, many of them are not even offered hormones, because and this is particular, when anytime you're looking at issues in healthcare disparities. Here's a little statistic. African American women have more severe symptoms. They enter
Mm-hmm.
menopause earlier, and their symptoms last longest. Like the average woman will have symptoms anywhere from 4 to 7 years. African American women will have symptoms for 10 years plus. And you can imagine you understand how
Yes.
long that is to feel
Yes.
not yourself, you
Yourself.
know?
Mm-hmm.
But they are least likely to get a prescription or to even have the conversation about whether or not this would be something that would be helpful for them. So there are a lot of women who are symptomatic, and they're not being quiet about it, but they're
Right.
going to alternative routes.
Sure.
So they're trying herbal preparations, or they're going to someone for a pellet, or there's all these other things that I think we can say that are not as effective as hormones, but they know they want relief. They just
Right.
don't know where to go. And they've been sort of scared off of the most effective route for treatment of their symptoms.
I mean, really, they're listening to whoever's talking. And right now,
Exactly.
if if you're not there for your gynecologist to talk to you, or the gynecologist doesn't have the information and doesn't feel equipped to talk, they're going to listen to somebody else. What do we
Yeah.
need to do to close the health equity gap that affects all women, in particular women of color? Where do we start with that? Does the telemedicine, does the ability, these companies we see, these femtech companies that we see, opening this up to everybody, does that start to help and close that gap?
Well, first you have to start with educating women and setting expectations for what that relationship should look like. You know, as a woman, and particularly a woman of color, what does that interaction look like? And we've
Mm-hmm.
also got to do a better job on training physicians,
Right.
because and I say we, and I put myself in that category, we as physicians are taught things that are not true. I mean, there are certain biases that we have in how we administer care, or things that we think. Because coming up, I heard two things when I was training. That African American women didn't have, their hot flashes weren't as bad, so they weren't as symptomatic from menopause. That was one. And the second one that have been taking to the bank is, oh yeah, and you don't have to worry about that because Black women don't get osteoporosis. Not true and not true. But there are things, when you talk about equity, you have to look at how much of the disparity in race is really due to poverty, lack of access to insurance, and and not being able to interact with the medical community in a respectful way. Right. I mean, and so even when you sort of control for socioeconomic status, African American women are still not getting the care that majority women do, and that is because that's sort of, we got to work on it, Right. But I think that one, and I say in summary, women have to know what to expect and when to advocate for themselves. Right. And two, we have to train physicians better to be a little bit more sensitive and take some of the assumptions that we put into this equation out of it.